Sure, we're ready to. Good morning, everyone. Good morning. I'm Susan Fordyce, the president of Mental Health America of Greater Houston, and I want to welcome you all here today. You know, as we were planning this function, we thought, what does success look like? And it looks like maybe convening 100 people that have an interest in this topic. And we had more than 180 respond that they would be coming, so hopefully more will be coming in and joining us as the morning unfolds. But it is great to see this many folks here who want to talk about integrated care. MHA first began working in this area in late 2009. There's Dr. Martinez. Thanks to the investment and the leadership of the Hogg Foundation for Mental Health, we have been able to work as part of statewide learning communities, and we've been on this wonderful learning journey for about 6 years now with many others across the state and in Harris County. So with forward-thinking grant-making, 1115 projects, and many others beginning their own integrated processes within their organizations, we have made tremendous progress in Texas. You know, so often we find ourselves talking about being last or near last, but not in this area. So we're very proud of that. But as we go forward, we really need to think about the progress we've made, and we want to not just sustain it, we want to build on it. So we have to address the barriers and the threats that remain in place to that progress. So here we are, and this is the perfect place for this conversation. We are immensely grateful to the Center for Health and Biosciences at the Baker Institute for opening their doors and welcoming us in today for today's forum. We hear a lot about integrated care, and we just want to make sure that we are all on the same page. So there's a card on your table with a few definitions. And we're going to make sure we're on the same page by putting them in writing and having me talk about them for just a minute. We have a very concise definition from the Hogg Foundation for Mental Health: the systemic coordination of physical and behavioral health care. And again, to be sure that we're on the same page, when we refer to behavioral health, we are talking about mental health and substance use. And another definition from the Agency for Healthcare Research and Quality: the care that results from a practice team of primary care and behavioral health clinicians working together with patients and families using a systemic and cost-effective approach to provide patient-centered care for a defined population. So integrated care can take place in a variety of settings, and it doesn't always look the same. But at its core, it involves an interdisciplinary, team-based approach that addresses all of a person's health. It has sometimes been described as the neck, linking the health care of the body to the health care for the brain. What a concept. So now it is my pleasure to introduce Dr. Vivian Ho, who has made it possible for us to partner with the Center for Health and Biosciences for today's event. Dr. Ho is the James A. Baker III Institute Chair in Health Economics. She is the director of the Baker Institute Center for Health and Biosciences. She is a professor in the Department of Economics at Rice University and a professor in the Department of Medicine at Baylor College of Medicine. Her research, which is widely published in economics, medical, and health services research journals, examines the effects of economic incentives and regulations on the quality and costs of health care, something we all care deeply about. Dr. Ho has served on the board of scientific counselors for the National Center for Health Statistics, as well as the NIH Health Services Outcomes and Delivery Study Section, and she is a founding and current board member of the American Society for Health Economists. So please join me in thanking and welcoming Dr. Vivian Ho.
Thank you for that warm introduction, Susan. Welcome to the Baker Institute. I know some of you are here for the first time and some of you have been here before. We're delighted that you could take time out of your schedule to participate in this very important event. Earlier this week, I got onto the National Institute of Mental Health webpage. I don't get time to visit there very much, but I thought I'd look at what they've had in terms of cost estimates for mental health care. Surprisingly, their data is from the year 2002, which shows you that really there has not been enough analysis about the economics and financial financing of mental health care. But I'll tell you those 2002 numbers. They say serious mental illness costs $317.6 billion per year in this country. The more interesting thing is the breakdown. $193 billion is due to lost earnings. So most of it is due to lost earnings productivity. $100 billion goes towards health expenditures and $24 billion goes towards disability benefits. Okay, so compare that against in terms of, what we think are the most important diseases in this country. If you look at death rates per 100,000 in the United States in 2010, the two most significant diseases are circulatory diseases and cancer and tumors. So 162 deaths per 100,000 for circulatory diseases, 129 for cancers and tumors, and mental health and behavioral disorders is well below this with 9 per 100,000. Okay, that's only one measure of health status, though. If you then look at disability-adjusted life years lost in the population in 2010, mental and behavioral disorders are at the top of that list with 3,576 disability-adjusted life years lost per year in the U.S. due to these disorders, and then circulatory diseases is behind that with 2,987. Now, the Mental Health Parity and Addiction Equity Act of 2008 was passed in part to address this issue, and it required group insurance policies to provide increased parity between mental health and substance use disorder benefits and the standard medical and surgical benefits. Following that, the Affordable Care Act strengthened this equity by making it also available to individual insurance policies. So this increased access to mental health care supposedly for people buying insurance through the individual marketplace, and then anybody who was newly getting insurance, and we know that a lot of people have become newly insured because of the Affordable Care Act. So now, because of this, we will have increased health care costs, right? We get more people insured, they're going to go out and seek care, and this is going to lead to substantial increases in expenditures. But if you go back to those numbers that are on the NIMH webpage, the bulk of the loss from mental health is disability, and sort of lost work benefits. So we increase health expenditures, but we're actually going to have more proportionately to gain in terms of improved productivity in the economy. So overall, overall, this is actually a good investment in terms of what we're going to get for our economy if we actually succeed in getting better integrated health care. So accountable care organizations, which are also receiving a big push under the Affordable Care Act, require coordinated care, but if you look at that literature, there's still, it's still in its very initial stages, and the data that's coming out on the outcomes and the cost savings from accountable care organizations is really on the medical surgical side, and there is almost nothing in there about mental health. And so that's what the panel here today is going to discuss, and that's what today is all about. Thank you for coming, and look forward to a productive discussion. And
thanks, Vivian. I'm Elena Marks, and I'm wearing 2 or 3 hats today. I'm the president and CEO of the Episcopal Health Foundation, but I'm also a health policy fellow here at the Baker Institute, and Vivian and I have been partners in crime for many years now, and every time I'm with her, I learn something fascinating, and I think of the next project we can do together. I'll put in a plug today for our Health Reform Monitoring Survey series. We have 13 briefs that have been published, and we are tracking the impact of the Affordable Care Act in Texas with quarterly consumer surveys that are particular to Texans. Today, though, we're talking about a different topic, and we have an embarrassment of riches this morning with our panelists. We have people who are at the top of their game in their fields, and while they all work together, they have very different perspectives because of where they work within the integrated care industry, which is actually going to become an industry if things work out the way they ought to. I'm not the expert in this area, and my job this morning really is to move this along. So here's what the flow will look like. We're going to start with very quick introductions. You've got everyone's bios. It could take the entire time we have together to tell you the fascinating backgrounds of each of these people. So we're going to do quick introductions by each panelist, and then we're going to break the panel into 2 topics. The first one is going to talk about how we prepare providers for integrated care delivery. You heard Susan talk about what it means is really treating the whole person, and that requires a different kind of healthcare delivery than what we are all traditionally used to. So our first panel is going to talk about what is it that providers need to do and that programs that prepare providers need to do to get us ready for that. And we're going to have comments first by 4 of our panelists, and then we're going to do some Q&A. Then we're going to switch topics, and we're going to move to the financing for integrated care. We all know the rallying cry that there's not enough money devoted to mental and behavioral health, and that's true. But in addition to there not being enough money, there are also issues with how the money that is available is allocated and spent. And our panelists today are going to talk about what the barriers and opportunities are within that system to use the money that's there more effectively, but also we, of course, want more money into the system as well. And again, we're going to have remarks from 4 of the panelists, and then I'm going to do some Q&A with all 6 of the panelists. Then we're going to stop, and we're going to open it up to all of you, and you are welcome to ask any questions, ideally on these 2 topics, but anything that you think these panelists can answer for you. They have a wealth of knowledge, and we want to be sure that you go away with information that is helpful and useful to you. And that's our goal for today. This is the beginning of a project that MHA is conducting that ultimately will lead to the development of recommendations to decision makers about how to improve training for integrated care and how to improve the financing structure. So we want to get you all engaged so that you're ready to help MHA formulate broad-based, community-driven solutions so that we can advocate collectively with one voice and get what we need. So with that, if we can ask each of you to give us your name and where you work, and then we're going to start with Dr. Minkoff.
So I'm Ken Minkoff. I'm a psychiatrist. I'm the director of system integration with the Meadows Mental Health Policy Institute. And then I consult nationally and internationally as part of an organization called Zia Partners, which is based in California. Am I going to start talking, or are we just going through everybody's name?
No, let's let everybody introduce themselves, and then we're going to start with Dr. Minkoff up here at the podium.
We're a well-integrated team of panelists.
We're trying. We're trying.
I'm Steve Schnee. I'm Executive Director of the Mental Health and Mental Retardation Authority of Harris County.
I'm Dave Buck with Healthcare for the Homeless Houston.
Good morning, everyone. Octavio Martinez, Executive Director for the Hogg Foundation for Mental Health. We're part of the Division of Diversity Community Engagement at UT in Austin. I think pertinent for the discussion today, also happen to be Chair for full disclosure of the Meadows Mental Health Policy Institute, as well as the Chair for the Behavioral Health Integration Advisory Committee that is giving recommendations to the Executive Director for HHSC.
Morning, I'm Jair Suarez. I'm a psychiatrist with UT Health, where I'm the head of the department and also the executive director for the Harris County Psychiatric Center.
Hi, good morning. McLean Sampson, assistant professor at UH Graduate College of Social Work, and I'm also the principal investigator for 2 HRSA-funded behavioral health integrated care training projects that we train our students on. I'll talk about that later.
Great. Okay, we're going to start with brief presentations up here at the podium, first by Dr. Minkoff, then Sampson, then Suarez, and then Martinez. And they're going to each give you a little bitty different perspective on how we get ready in terms of our providers for integrated care delivery.
Elaine, do you want to talk about the
events page? Yes. So these are researchers. A lot of them are researchers, and there's a lot of incredible data out there, and many of them will be drawing on that data or referring specifically to papers, and MHA will have an event page that relates to this event, and any of the papers that are mentioned or that are supportive of what these panelists are talking about will be posted to that event page within a few days. Do you want to come up?
Thank you, everybody. I'm delighted to be here, and I've been thinking a lot about how to condense a huge amount of activity out nationally into 5 minutes of take-home wonderful bullet points. So I'm going to try. Bullet point number 1 is one of the big meta messages here is that MHA of Greater Houston is inviting you to come together to be a policy forum and to help develop some recommendations for advancing integrated care across Texas. And I just wanted to say on behalf of the Meadows Mental Health Policy Institute, and I know Octavio has talked about this as well, the Hogg Institute, that the Hogg Foundation, that we all are in the same integrated team. And we want to coordinate the policy recommendations so that legislators and policymakers get an integrated message that helps to make things clearer about how to act. Secondly, I want to let everybody know that one of the things the Meadows Mental Health Policy Institute has been doing as part of helping to advance this is that we have been sponsoring for the last year and a half a networking group on primary care behavioral health integration that Ali Posada has been very active in. And you are all welcome to join. There's basically monthly teleconferences, and we have information, distribute resources, have mini speakers, and create conversation. And it's been very helpful and productive, and on the events page would be how you can get connected to it if you're interested. Point number 3, this part of the panel is focusing on workforce development and training and competency development. And most of the panelists are going to be talking about training in the sense of undergraduate or graduate education training, so training people before they come to work. However, that's only a small piece of the overall puzzle of developing competency in this area. Basically, what we're coming to understand is that people with overlapping health and behavioral health needs are the expectation, not the exception. Where complexity is present, it's associated with poorer outcomes and higher costs. Everything that we've done historically, from data collection to cost management to program development to service delivery, has been developed based on keeping those things separate and looking at diagnoses rather than people who may have complex needs. Therefore, when we're thinking about competency development, I want everybody here to be thinking about this. This is not just some new generation of other people, and we're not just training a few specialists to go out there and do this. Essentially, we need to all be in the business of thinking about how to develop our own integrated competencies and develop those competencies inside whatever work we do and inside the teams or programs that we operate where those people are showing up all the time. The starting place for integrated care and learning how to develop integrated competency doesn't actually start with the team. It starts with any individual person saying, how do I do this differently within my job? And whether you're a psychiatrist or a nurse or a social worker, a case manager or a peer support person, you're going to be meeting people who have both kinds of issues. And the starting place for that meeting is to say, welcome. I like working with people who have complexity. I'm here to be a partner with you in helping you to address both your mental health issues and your health issues and your social needs in service of helping you to have a happy, hopeful, productive, and meaningful life. And just being able to start to say that and think, what does that mean for me to do differently inside my work, starting today, tomorrow, is a step forward. Advancing the competency starts with building things. You all know the triple aim. There's a new language I heard recently called the quadruple aim, which is improve the fourth part of the triple aim, improving the experience of care, outcome of care, cost of care. The quadruple aim is improving the experience of providers. So part of this is helping people develop more effective partnerships and teaching people the basic competencies for how to go about doing this in a value-driven way. And surprisingly, it's not that the people who get to do this, it's like case managers suddenly becoming experts in diabetes. It's helping people use their existing skills within the area they have to work better and more effectively with the people in front of them, to be interested in how to help those people put together multiple recommendations to make progress. The next issue is, how do we develop competency? So one of the things that we're learning in those of us who think all over the place about things like workforce development and sustainable workforce development is to say that basically training alone is the evidence-based worst practice for sustainable workforce development. And we send people a lot to trainings, and we're always mystified why the training they went to, however brilliant, did not result in them changing practice. Because practice change is an organizational feature, not simply the result of attending a course. So the organizational feature means, how do we organize ourselves within what we do in any program so that the practice support is continuously reinforced within the way our program is designed by policy, procedure, paperwork, practice, supervision, and so forth. And these structures are the things that those places that are moving down the path of delivering integrated care are spending a lot of time thinking about. One piece of work that I've been involved in that we're pretty proud of at Zia Partners is that we partnered with the Center for Integrated Health Solutions and MTM Associates to develop a toolkit for organizations to advance their ability to deliver integrated care and integrated practice, integrated competency, and so forth. It's called the Organizational Assessment Toolkit for Integration. It's freely available, and the events page will tell you how to get hold of it. And Allie's learning community is working with it to try to help people make progress. And it connects the organizational support elements to performance improvement at the program level to help people develop competencies incrementally over time. Competency is not just clinical. I have some cool new friends from AmeriGroup and Anthem who are sitting over there. There are probably other payers here. And if you're a wise payer, you know that just because somebody gave you a contract to manage health and behavioral health did not automatically make you competent in integrated utilization management and funding oversight. So even as a utilization manager or care coordinator, you have to develop new competencies within your basic framework, and they have to be supported by your organization. The next thing I wanted to talk about is the degree to which things like teamwork, okay, not only are everybody have to develop competency individually, they have to develop competency to work as a team. And they have to work as a team in settings where they may never have learned to work as a team before, like in primary care settings or in behavioral health settings, where unfortunately many psychiatrists here in Texas, is my observation, never learned to work in an interdisciplinary team, even just within behavioral health. And learning how to work as a team, again, is not a course. It depends a lot on attending to very specific details about how that team is going to function and operate with respect and so forth. So one of the things I wanted, another resource to direct you to, is the AHRQ, the Agency for Healthcare Quality and Research, I think I got Research and Quality, issued a report earlier this year where they took 15 or so leader, or maybe it was 12, leader provider organizations that had advanced the development of integration and dug into details about how they did it organizationally. And it's a fascinating reading because although all the organizations were different, the elements of what it was requiring to build integrated practice and to support the competency of the staff was quite detailed and thorough and very interesting to anyone who's a program manager. So my final sentence. So what I would like everybody to come away from is thinking, what can I do in my work, in my program, in my team, starting today, to help people realize that they're already working with people who have multiple needs and to start advancing their competency to be more effective in engaging those people in an ongoing relationship to help them manage their needs to have better outcomes over time. Thank you.
Good morning. What a beautiful venue to be sitting in. I appreciate this nice space. So my name is McLean Sampson, and I am an assistant professor at University of Houston Graduate College of Social Work. So I'd like to talk to you about social work's role in this integrated care movement, and also talk to you a bit specifically about how at the school we're trying to prepare students. So I was looking at the agenda, and I'm supposed to talk about social workers on the ground, and I will. But anybody who's a social worker in here understands that most of our training really happens in that first job, that second job, right? Like, no matter what we learn in the class and what we learn in our field practicum, we learn it once we start working. So I talk about learning as though it's in the classroom and then out in the field on the ground. Social work, our goal overall is to improve the functioning of individuals, organizations, communities. We can do it through direct social work practice, counseling, or maybe some intake at a hospital, but where you're working directly with individuals, or we can do it through policy, or you can do both, which would be great. So the way social work fits into integrated care is ideally a social worker would work alongside a team that's already in a medical setting. So the social worker would be somebody like a behavioral health consultant, and we would help with intake probably and a very thorough psychosocial assessment. We would be able to do brief assessments in mental health and substance abuse, and therefore we become a really strong patient advocate who can be with the patient alongside them, but also be a part of the team. So we aren't pitted against the team where we're constantly trying to convince a medical professional why they should care that if they discharge the patient, he or she will be homeless. But rather, we're building knowledge base among the team of why being homeless upon discharge will result in worse medical outcomes and will result in the person coming back and becoming what we usually call a frequent flyer. So ideally, our people work within a team. Now, if you know about integrated care, it occurs along a continuum. So when I talk about that, that's all the way integrated, where we're in the same building, we are working with the primary care physician, a psychiatrist, maybe a psychologist, and then the other medical professionals who are there, and you're all working as a team on one case. But it can also occur in places that are co-located where there are social workers and medical professionals, and we have different patients, but we still consult with each other. So the point we try and get across with training and through our curriculum is really what Dr. Minkoff was saying, is that this is a new era of healthcare, and social work can no longer be comfortable just learning how to do something like private practice or learning how to do something like discharge and referral that we would typically do. We have to now be able to talk across professions. I have to be able to talk about a case in a way that holds the attention of the primary care physician. I have to give respect knowing that there is a medical diagnosis, even though I may have picked up that there's an undiagnosed mental health diagnosis. So we really have to teach our students to have excellent communication skills, but also assertiveness training, which is a new thing for social work. Anybody that knows social work, we're usually pretty deferential. But when it comes to patient advocacy and being part of the team, we need to be able to be assertive and have leadership, have excellent communication skills. We need to know some basic medical terminology. We need to know how diabetes can affect their mental health and their mental health can affect their diabetes. We need to know some brief interventions for diabetes management, because ideally the behavioral health consultant is the one that takes that patient and explains how these interventions will work, thus saving some time for the primary care physician and being able to use our skill set of communication and knowing a lot about a lot of things. I also mentioned these training grants. So we are funded by HRSA, which is, can't even remember now, Health Resource Service Administration. It's from the federal government. But we're really excited about this because this means that HRSA, part of the federal government, has recognized how important it is that social work be a part of behavioral health and integrated care. So starting in 2012, we received funding to provide stipends and trainings to students who are willing to be clinical students, go out there and work in integrated care with medically underserved populations. As you know, social work is very focused on vulnerable and poor populations. So we're taking that and taking it into primary care clinics. Since 2012, we've trained about over 40 students, and I have funding through 2017, so we'll be training another 40 students. And just to give you an example of how integrated social work is with other professions, we have social work interns at several agencies at MHMRA with Dr. Schnee. We have people, or we have had people, we don't have anybody currently, at Healthcare for the Homeless. And we have people at HCPC. So you see, the best thing about social work being a part of this discussion and this movement is we're already team players. We understand how that works. We understand that there's give and take. So we're already out there. For us, it's really about teaching us how we fit into the medical community. Because a lot of social work students will be like, well, I don't have anything to do with that. Yes, you do. This is the new era of healthcare, is it is integrated, and even if I'm seeing somebody in my office, more than likely they're going to have a behavioral health disorder, like they're trying to quit smoking, or some kind of chronic pain disorder that's affecting their mental health, and we now need to know about that. And I'd be happy to answer any questions when it comes time for that. Okay, thank you.
Okay, well, good morning. I'm Jair Suarez with UT Health, and what I want to talk to you mostly about today has to do with, well, the part that we do more directly, where I can, speak from personal experience that has to do with running a large training program for psychiatrists in our area. So our department is actually a large system involving different partners. I mean, starting with a sizable inpatient acute psychiatric hospital, HCPC, at 250 beds operational at this point. And then we've grown quite a bit the past 2 years to have a very significant presence across different community clinics. This expansion actually gave us the need and the ability to learn more about how to best integrate care with, primarily with other medical specialties. I mean, when we go to these community clinics, we have family docs, pediatricians. Some of these clinics are more multi-specialty clinics as well. In each one of these clinics, we usually place a psychiatrist and a therapist. The therapist generally master's level social worker, sometimes a PhD level psychologist. And that's given us the ability to develop a larger team that is learning how to work in a better integrated fashion with colleagues from other disciplines. It's also great because then our students, the medical students, when they go in their outpatient rotations, they get to experience that. We do run a large training program where it's about 50 trainees on any given time. We now take 12 new general psychiatry residents per year. And primarily over the past 3 years, they've gotten some great new opportunities to experience integrated care. Initially with a partnership with the VA, where through the VA community clinics, our residents are, learning how to work with family docs and psychologists, social workers, and professionals in other areas. And then more recently, we've been part of a large Harris Health expansion where for several of the Harris Health clinics, as they expanded behavioral health services, we've had the opportunity to place psychiatrists and therapists there, and our residents get to rotate through some of those as well. We've seen that also through some of the UTP, University of Texas physicians sites in the community where, behavioral health is as an important area. It's great to see our colleagues more and more wanting us there to work with them collaboratively. So the part where we are training the medical students and the residents to experience that early on, to emphasize how important it is and give them the skills to actually do it, I think we are much better positioned now than we were, 3-4 years ago, and that's exciting to all of us. For the component, which is very important as well, as pointed out by Dr. Minkoff earlier, well, part of the equation is, the students and people we are preparing, physicians in training. The other part, which is probably more important because it's more sizable, are the ones already in practice. What do we do to help them? And for that part, there is a lot more than that we could and should be doing, honestly. We have some continued education programs. I mean, those offerings could and should be expanded. I also feel there is an important role for professional organizations, like national professional organizations like the APA, to embrace more. If you look at the let's say, last couple of years program for the American Psychiatric Association, you will see some good sessions, some good component, but I think we need more and to make those more available, as well as developing opportunities here more locally for folks who are already in practice, who did not learn that through their training, and depending on where they want to, well, I suspect that most anywhere they want to practice, they will need that, and they could certainly benefit from learning how to work as a team and how to best collaborate with primary care specialties and colleagues from other specialties. And that's about what I had to say, and I'd be glad to take any questions once the question and answer phase comes up. Thank you.
Thanks.
All right. How's everybody doing today? I hope you're doing well. Excellent. We were in church, I'd expect a much louder response, but that's okay. We're not there, right? Would also like to first start off by thanking MHA, and especially in the leadership of Susan Fortis and Alejandra Posada. She's done a wonderful job bringing you all here together. They have been great partners and grantees of the Hogg Foundation, so I definitely want to recognize the work that they're doing. And they're a fantastic resource now when it comes to integrated healthcare. So don't avail yourselves of their skill set. Well, what I'm going to do is, being the last one before we get moving on, is sort of turn the discussion to a little bit higher level. Really going to talk a little bit about the Institute of Medicine committee that I was a part of, just a little bit. Now, the reason being why, because we're moving toward a performance value-based system. So there's huge transformations occurring in healthcare. We're all aware of that. What does that mean? Well, what it really means, I believe, is that it says, one, that the current status, obviously the status quo, is not working for us. We, at one time, were the best healthcare system in the nation, in the world. That isn't the case anymore, and we all know that every few years we seem to drop a few more notches. Why is that happening when we're in fact spending more per capita, practically $9,000 per person, here in the United States per year, more than any other nation on the planet? And yet the outcomes aren't the ones that we're expecting. Well, for one thing, is we've been a very cost approach system, reimbursement for cost. And so the current fee-for-service system really incentivizes very different things, and we're going to talk about that more in the second panel. So, what's really important in you think of all the different variables that fit into creating an integrated healthcare performance value-based system. One of them, obviously, as we're pointing out, is education and training. Well, one of the big drivers out there, one of the big policy levers that we felt that existed was obviously the graduate medical education that we spend annually. Practically about $13 billion is what we spend in the United States. It's a lot of money. Now, what's interesting is the question then came up is, what are we getting for that? Well, it's a cost-based approach, and so we're not getting really what we're expecting. Are we creating team-based care? No. Are we having the health outcomes that we would like to see? No. Are we cultural and linguistic competent? No. Now, there are exemplars out there, and some of you are involved in that, but I'm talking about across the nation and as a standard for our healthcare system. So we're woefully inadequate in many respects. So the Institute of Medicine got together and they had a committee. The report came out in 2014, Graduate Medical Education, that meets the nation's health needs. So what do we want to do from this point, this very policy that exists out there, this $13 billion, how can we influence across the entire nation? Well, one thing is, let's put together actually a graduate medical education system that in fact really pushes us to our value-based approach. Because we never really have expected much for this money. And this is our money, right? This is tax dollars that are being used to train physicians, help to train me. And yet, what happens when someone actually finishes their residency program? Are they expected, even though CMS, and in certain programs it's more than others, but there have been CMS dollars, federal dollars, from all of us that in fact have been used for that training. But then when the folks come out, we have the option of not even wanting to sign up or be part of Medicaid. Is that correct? Should that even be allowed? Why shouldn't we expect, since we're putting part into your training, then maybe you need to give back? Maybe 2-3 years, whatever the case may be, and then maybe you can decide to opt out. But that would be a real game changer, in fact, if we then expected all residency, at the end of residency physicians as they're moving out, that they need to be part of the Medicare Medicaid system and be able to, because those are huge populations and those are big payers out there that currently exist. So that was some of the discussion that we had. What was interesting, though, for the committee, though, as the discussion went on about GME, was we first had to get past the question, should the federal government even be funding GME? Well, let me tell you, folks, that was some really robust discussions that happened. And it didn't just happen in one meeting. That went on for several meetings. We had economists, we had all different types of interdisciplinary folks at the table, and there were some good arguments were being made that if we're not getting what, a bang for our buck, then why should we even be investing in it? Let's let just the market take care of it. Well, that didn't really sit well with a large number of our folks there, as you can imagine. And also, can you imagine how, talking about, disruption, how disruptive would that be if that funding silo was just cut off? So we realized that probably was not the case, or the best approach. But in fact, it had to be a transitional approach. And if you look at the report, you'll have the details in there of what's being recommended to Congress to consider about how to actually take us from a cost reimbursement system for graduate medical education to a performance value-based system for residency training. And this is only for physicians, which includes obviously all the specialties, including psychiatry. Now, the committee, we tried to actually include, we wanted to be interdisciplinary. We wanted to include nursing. We wanted to include pharmacology. We wanted to include the other disciplines out there because we know the team-based approach is really important, and it's in the report. We must be a team-based approach. But our hands were slapped and said, no, that's not your charge. That's the way it works with committees. You can only address this one little issue. Okay, fine. So we stuck with that. But we kind of squeezed it in there. So if you read the report, you'll kind of find that in reference to interdisciplinary, team-based approaches to the delivery of care. The other thing that's very interesting, obviously, is that what we were trying to do in the report is also keep the eye on the prize. And what is the eye on the prize? It's everybody here in this room, all our communities, all our families. We have to get back to looking at health outcomes, looking at those metrics and infusing them and making them part of our training, not only at the residency level, but really going upstream. We need to really get it to medical education, and not just medical education, but social work education, nursing education, all of the disciplines. And some of the disciplines are farther ahead than others when it comes to really incorporating and understanding really the social determinants of health, let alone the social determinants of mental health, as well as cultural and linguistic competency, team-based skill set approaches to the delivery of care. All very key. The one thing, though, that has really come to foresight is, okay, is this report making a difference? Well, apparently it is. On August 4th of 2015, the U.S. Congress asked the GAO, the General Accounting Office, to evaluate the current structure of the GME programs and provide recommendations for improvements, especially as it relates to transparency, streamlining, and increased oversight. Basically, they've taken quite a bit from the report, and they're now having the GAO take a look. So it's moving forward. So the policy lever is working. How long it will take for actually to see real changes happening the way GME currently is being financed, it'll take a bit of time, but it's definitely coming. And in the meantime, as you've heard from already in our panel, and what we'll hear later in panel B, is the other transformations that are occurring in healthcare, not only in the public, but also in the private sector, realizing that we must move to a performance value-based system because the cost reimbursement system, the fee-for-service system, has not achieved the goals that we were looking for. With that, I think I'm going to turn it over to you, Susan, because I think that sets it up for finance.
So we're running a little bit behind because there's just so much great material, and so I want to abbreviate this part of the Q&A because I really want the audience to have the opportunity to ask questions. So let me throw out two and ask you to address one or the other or not and save it for later because I'm dying to get to the financing part as well. And by the way, Octavio was modest about talking about the IOM results. He didn't tell you he's on the committee, and so it was a great coup for Texas to have him representing us. So two questions. We heard a lot about team-based approach. Ken made the point that we can't just focus on training, whether it's in an academic setting or whether it's someone goes to a training, because the work actually happens in organizational, institutional settings. So I'm hoping that someone can give some examples of best practice in training that is incorporated into an actual work setting. And then second, if you've got policy recommendations that you want to key up before we get to the end of the year with policy recommendations, this is a good time. So I'm just going to go down the line. McLean?
So for
Thoughts?
training, okay. So what we found, okay, so first let me explain. In our program, the way training works is social work has field practicums. So the entire 2 years that they're in classes, they also have to be at a field agency working. So with the HRSA grants, we do specialized field placements, and so I do my best to get my students into integrated care settings. And that's the first step, because you really want to try and get into that setting while it's integrated, not to go into it as one individual, especially at the social work level that's trying to make it integrated, you see. So we place them in those integrated care settings, and then we also require them to come to workshops that are interprofessional. So what I mean by that is I usually have a panel that is composed of people from different professions, not social work. So psychiatry, psychology, a primary care physician. Sometimes we even have a client that's benefited from integrated care. And so the students are able to see, they have to listen to how a case would go through an interprofessional process. And then a student would be on the panel having to talk about how social work would contribute to that case. So really for us, what I've found is we have kind of a bi-directional learning process, that our students have to continually think about how social work would fit into those roles, and they have to articulate how they would fit into it, because sure enough, they keep saying, well, I would make sure that they have bus tickets, and I would make sure that they have certain health care. So we have to make them actually think a bit deeper about how they would be integrated into that team, and then also they have to see the role model of how it is working. And then the best practices that I have seen is I've been really impressed with the federally qualified health centers here. So this isn't one, but for example, when I had a student at Healthcare for the Homeless, and my students were working with Baylor residents, and they were working with the homeless population that the social workers are drawn to work with, but they have to also work alongside these residents, and then the residents are learning from social work. Because another thing that predicts acceptance of this integrated team is that when the different professions actually respect what the other professions bring to the table. And only by working together can you see what unique aspects we can bring. And then the federally qualified health centers and Harris Health System, I mean, the other panelists can talk more in depth about that, but I'm really seeing places where there is actually integrated care, and the social workers are being used as these consultants who talk about the social ramifications of the treatment. And so they are able to help the treatment be more effective.
Where else are we seeing best practices in your experience, any of you on the panel? Either in our own community or around the country. Some of you have experience all across the country.
This is one that's coming down the pike, Elena. So obviously in Austin, Texas, I'm sure most of you have heard, we have a new medical school coming on board, the Dell Medical School, going to be part of UT Austin, already is. Well, one of the things that I think is going to be really important, obviously, do we have the training sites? You know, it's one thing to do the didactics. You can do the theory, everything we're talking about here, but if you're not actually then in the field with attendings that also understand and have the same skill sets. Right. So, you know, there's going to be different levels of training that have to happen, right, for this to actually really be effective and efficient. But you have to have the training site. So one of the things the Dell Medical School has just done, we kicked off a joint venture with Huston-Tillotson University. It's a historically black university there they're in Austin. They're in the process, and they've already broken ground. They're building a new behavioral health wellness center. So it's already being designed as fully an integrated physical and behavioral health clinic. But the thought is for it to be, and it's being designed from the very beginning, to be a training site not only for undergraduates and graduates, but also for medical students and residents, because it's going to be utilized by both universities, Huston-Tillotson University as well as the University of Texas and the Dell Medical School. So I think that's going to be really something exciting. It's being designed from the initial, not only from a clinical standpoint, but also from a research and design standpoint, really to want to be really much more provocative and be able to learn with but not just from our communities. So I think that's going to be something coming down the pike that's really exciting.
Ken, something from outside of Texas that you've observed?
Well, one of the reasons I gave the reference from AHRQ is because they did identify 12 leading providers that are worth understanding in some level of detail. And I wanted to talk a little bit about, I'll just mention quickly one of them and something about how they operate. Many of you have heard of Cherokee Health Systems in Tennessee, and they're one of the national model and very early adopters of integrated care. And one of the things that's very interesting, having been participating in this Tennessee project, which I'll mention in the financing section, but when they come to the meeting at the state level, they introduce themselves not as a mental health provider or a substance provider. They introduce themselves as we're an integrated health delivery system. And that messaging affects how every single person is hired and the way they think about every single program. And that is fundamental to the training and orientation of staff. If you say, I'm hiring you to be a mental health person, but in addition, you're going to learn how to deal with people who have health issues, you're already not providing the right context. So, and then you have to put people into situations where they experience themselves in a team that is caring and attending to both issues at the same time. And you have to, there's no one model for how teams operate. And many of you have heard of the concept of huddles. The idea in the primary care setting, everybody huddles together as a team to think about how the workflow of the day and the people of the day come. And there's an incredible literature about how people obsess about how to construct the huddle, which is only to say that everybody really has to get into that level of detail so the huddle fits your setting and your personalities, and everybody knows how to treat each other with respect, and everybody's opinions count, and you have a shared approach to the patient. So just talking about the social work, for example, and the social worker says, as McLean said, well, I'll get them a bus pass. But you're sitting with somebody, this is what the core of integrated care is, you have somebody with diabetes who may or may not have a diagnosis of a mental health condition, but they have a long history of trauma. They've been coping with this trauma by overeating for their entire life. They're living in a relationship where they have domestic violence. They have kids who have developmental delay. They have, one of their older kids has a substance problem, is in trouble with the law. I mean, those are the people we're dealing with. And the doctor says, don't eat donuts. And, and if you eat donuts, I'm going to make you feel bad. Like, oh, good, now we're part of your trauma. And so the job of the social worker is learning how to be in that team, creating a relationship with this individual and this family so that they can actually think about why, how and why, and in very great detail, what can we do to just take some steps to believe we deserve to have better health, and to think about how to actually do it in the context of our real lives. And to me, that's the essence of what social workers can do, case managers can do, behavioral psychologists can do, and peer support people can do. So as a policy issue, just for Texas, Octavio is, I thought, being very artful, laying it out on like the feds pay for graduate medical education, but Texas doesn't, which isn't true. What do we want to do?
I have witnesses.
And you know how we in Texas just love to take federal money whenever we can.
Oh, now it's going to get fun.
But the point is, can we start to develop some basic core competencies for what we're trying to develop in all of our graduate training and undergraduate training, so that people each have a set of core competencies and a set of understandings about what integrated care is about, as just a basic workforce development activity. That would be a powerful policy statement right there as a piece of workforce policy, interdisciplinary across all universities and training programs that receive public money. And I could go further, but I'll just stop with that one.
Well, thanks for stopping right there, because you're next up.
Oh.
We're going to move on to the financing piece, and let's all keep our comments brief so that we can turn it over to the audience. But let's start out with you, Ken, on what's wrong with the way we're structured to pay for this kind of work.
Okay, so hi again. Picking up where I left off with the idea that this is the whole issue of integration, and Octavio said it very well. This is a major transformation of the delivery system. So the most important thing not to think is that there's some tricky gimmick. If we just write the tricky gimmick into law, then we're going to be fixed. We have to actually be looking at funding for integrated health care at every single level, and how the financing and the cost economics and the outcome measurements are built into all of the iterations of places where funding policy meets delivery. So I'm just going to walk through this in a little bit of a sequence, and so you'll see. So the first thing is everybody should start thinking about how to do integrated care within the resource you actually have. Because if you're waiting for somebody to give you more money before you start, you're in the wrong mind frame. Secondly, any existing funding barriers that make it hard to do that need to be identified and proactively eliminated. And so if somebody says, well, if I'm, very simply, if I'm a primary care physician and I talk to somebody about something other than their diabetes, and I talked about their life, I can't document it and include it in my bill like I'm addressing complexity. Okay? I mean, that's simple. Then on the next layer up, there's a sequence of things in the way basic reimbursements are developed that are inconsistent with what we're trying to do. And so some of them are things you well know. The idea that you can't bill for two kinds of visits on the same day. And there's actually, in one of the pieces of federal legislation, somebody is trying to correct that. There are other things about, who are reimbursable as part of the care team is another set of issues. Now we're trying to get a broader interdisciplinary team, but only certain people can actually receive reimbursement, which is, one policy bumping up against another. If you look at Medicaid financing policy, Octavio was saying everybody should take Medicaid and Medicare. They should be required. And I'm thinking, why do we want to make them suffer? Bill Medicaid and you lose money. That's a rational thing. So one of the things as a piece of funding policy is, have we created a system where in our public dollar is ambulatory care incentivized or disincentivized? That's the way I would frame it. In other words, are we going to pay more effectively for higher end acute care versus supporting ambulatory care? Okay, that's a policy decision. On another level, you start thinking about how to support services programmatically. So how do we build for teamwork, for example? And then, even more important, how do we start moving our financing away at the program level now, away from the idea that we're purchasing service units as opposed to we're purchasing population management at the program level? Okay, so what this starts to involve is the capacity of payers to work with providers, and I'm still working below the big state level, to say, look, we have high need populations, we want to work with you. So you have the flexibility, not just to document a service code, but to manage outcome and cost for this population. And we will develop measures to ensure that you're not, creaming off the easy people, that you have access and engagement, and we'll look at health indicators, but also cost indicators. And we'll reimburse you accordingly with a case rate or a shared capitation or a variety of other mechanisms. At a policy level, we have to give, if we're going to hire managed care organizations, we have to give them the tools to do this kind of stuff. We can't say, hey, managed care organization, we're going to hire you, and then, but please, you can only pay for the things that our Medicaid agency could pay for. Okay? So that's the next layer. At a state level, we want to be thinking about how to build the support for progress and integration at all different levels, not to impose a top-down model of everybody does it the same, and not to assume that there's only certain specialized places where people get integrated care, but to start developing a regulatory and funding and improvement framework where all settings are moving in this direction. And we want to support it in an ongoing way. One of the project I mentioned in Tennessee, which is fascinating, is that, and we're consulting to that, but it's fascinating because the state, and this didn't happen overnight, but the state has created a multi-payer collaborative with all of their private and public managed care intermediaries and major insurers across the entire state of Tennessee to agree, even though they're still competitors and they have things that they can compete around, to start developing a common support framework for integrated care delivery with common metrics and common infrastructure so that providers out in all the different parts of Tennessee don't have to have a different kind of infrastructure for each payer that they're doing business with. And then they're going to be using, funding incentives like the health home waiver, which allows for enhanced funding for care coordination at a 90-10 match for 2 years, to support and they also have a CMS innovation grant. They're looking for the innovation dollars, not just to throw money in the system, but to support strategic implementation of change. So it's very important in Texas, the 1115 waiver is a good example, to say we don't want to just bring the money in. We want to have a strategy so that the money, however much it is leveraging capacity development across the entire system, where the state helps all the payers to work together with providers and communities to support their ability to develop integration rather than multiple parallel funding streams doing different things, so that we have an overarching strategy of using the limited resources we have most effectively and efficiently. I'll stop there. Thank you.
It's you.
Hello, and thanks for facilitating this great event. I'd like to be kind of concrete to kind of get us back to, at least the work that I do. I'm a family doctor that works with the homeless, and we've implemented a primary care behavioral health consultancy model within our clinic, and we have some successes and we have some abysmal failures. And I enjoy talking about what we could do to improve more than what we've done great. So I'll start there. The people that, the seriously mentally ill and the chronically homeless die 29 years younger than their domiciled or non-mentally ill counterparts. Most are from comorbid diseases. So how are we doing? Is this integration changing that? Well, I hope it is, but what's really happening? Well, we have no effective system that coordinates care from our FQHCs to our hospitals and to our subspecialty partners. How much would that cost? Actually, it'd be cheaper. So why aren't we doing that? And I think that then pulls us back to, I think, the context from which we've all been talking about today. And that is that it requires a new way of looking at both outcomes as well as our solutions. We have to first acknowledge that each of us comes from a silo. I come from my own silos. And in those silos, we have to be sustainable, we have to be responsible to our organizations. But how can we begin looking beyond these silos to a larger safety net in our community? And I think that this is where the healthcare reform really provides an opportunity for us. the opportunity is this new field called population health. And so let me then just go back to a second. We've heard triple aim of health reform. What does that mean? Well, we spend $2.8 trillion each year in health. That's more money than I can kind of figure in my head. That's more zeros. How many zeros is that? We don't get it. I don't get it. So 50% of that money, roughly, is consumed by 5% of the patients. So how much is that? Well, that's $1.4 trillion. Well, if we roll this back further and look at Texas, how much does Texas consume in that kind of budget of sorts? Well, 10% roughly is the Texas expenditure, or $280 billion. So if we look at some of the examples around the country of best practices, the easiest methodology is these care coordination teams, where it's high touch, low tech. So that's different than what we often think. We think the highest technology, that's what's going to solve it. But that is not true. It's really human connection. So these high-touch, low-tech methodologies decrease costs by roughly 30%. So 30% through care coordination decreases that $2.8 trillion. So then now let's go back to that piece that's right here, concrete, here in Houston, which is about the person on the street that has comorbid conditions. How is it that our system is affecting their care? Well, the behavioral health is great, and we did it, and we are still trying to improve it, and it's essential, because one of the big gains in care coordination is that we're connecting people with primary care, and we're doing it through behavioral health, a behavioral health team. So it's all centered around this integration, but we're also in the context of these drivers that have silos that are really, we now no longer have silos. We now have cylinders of excellence. So we can rest assured everything's better now. We really need something beyond these cylinders of excellence that really is a context for our community to look at these outcomes across systems, and I think this healthcare reform allows us the data to begin to do that. Thank you.
Good morning. Steve Genet, MHMRA, and I'm going to start by quickly talking about the elephant in the room, some of the current realities. As Dr. Buck indicated, we currently have a non-system of care. We have silos which have erected protective barriers in order to ensure their continuing viability. In the community called Harris County, we have incredible population growth, diversity, which speaks to where the nation is going. Our medically uninsured adult population is one of the highest in the state of Texas. And Medicaid in Texas has significant barriers around eligibility, services available, and the rates of reimbursement. And we all know what the state's position has been around ACA expansion. And so, as Dr. Buck indicated, we have a significant morbidity in our serious mental ill population compared to their, quote, normal counterparts. And this becomes critical to understanding as a part of moving forward in today's environment and making it work around integration. So the public sector is focused on adults with complex, severe, high acuity conditions, often multiple conditions with substance abuse, physical health care, multiple life needs such as living environments, and needing supports. They are financially challenged, and no single entity has the resources to be able to address these complex needs. I would suggest to you that integrated care is more than co-location. It really is a commitment toward collaborative partnerships which take time, build trust, and leverage resources. And it requires braiding current funding streams and expertise. It is hard work. So I want to talk about one example that is taking place in Harris County today. Thanks in large part to the 1115 waiver and its DSRIP projects. It has brought resources to the table that makes this work in process possible. MHMR has partnered with 4 FQHCs in Harris Health, our hospital district. The FQHCs have a variety of relationships, but what we're trying to do is ensure that we have linkages both into the FQHC, extruding our mental health services in their locations, and incorporating satellite FQHC physical health care into the MHMR major clinics. This is made possible because we have made a commitment to building out space for FQHC physical medicine. We have worked with the FQHC to build a business model which permits them to incorporate their best Medicaid rates with Harris Health case rates to cover MHMR patients for the services of the FQHC, and MHMR using DSRIP funds to supplement that if those two don't bring together to help them overcome the significant impact of incorporating the medically uninsured. As I indicated, MHMR is extruding its mental health teams and sending psychiatrists, social workers, nurses into the FQHCs, or partnering if they have those resources with them. One of the hidden payers that becomes critical to kind of think through is the pharmaceutical industry indigent drug program. MHMR is able to mine that program for our indigent adults to the tune of about $2 million in medication value that's provided by the pharmaceutical industry for the medically uninsured. In fact, we are able to distribute about 95 to 96% of the medications needed by our patients for this population through this funding stream. You've got to be able to think through how a person can be served in an FQHC without those medication costs falling to their bottom line because they can't sustain that. So bridging that becomes kind of critically important. We have partnered with the Houston Council around substance abuse and incorporated members of the LCDCs provided by the Houston Council into our clinics and other mobile teams so that we can address their psychiatric and their substance abuse and their physical health. And we're increasingly incorporating peer supports as a part of this and looking to another major part of integration being housing and partnering with housing providers, because that sits outside of, by and large, any of the funding streams. We're working through, and I won't say that we have all the answers, around information exchange. It is critical, real-time communication, so that providers in the system can share that information around patients. We have and building uniform eligibility processes so folks have documentation one time, not multiple times. We're looking at culture, processes, and cross-training so we can share each other's resources. Case management becomes critical with a population that often has difficulty getting from point A to point B, even when point B is just down the hallway. Housing is a major challenge for us in Harris County and around the state. And so in concluding, I want to say that I think while it is challenging, while it is difficult work, while we have to build that kind of communication and trust, it is truly working through and making a commitment to the level of integration. As has been said by several of my colleagues, we can't wait for things to change. We've got to make it happen within today's resources. Thank you.
Thanks to everyone. I'm going to move us into, you're our cleanup hitter.
It's all right. Let's hope I have something interesting to say now, right?
Pressure's on.
Pressure's on. Well, I think this is a very obviously key and important area because everybody says, okay, how are you going to finance this, right? So it's extremely important. Well, we know the volume-driven healthcare system doesn't work. We see it in the outcomes that it gives us. So we're talking about moving toward value, right? Well, the fee-for-service system, what has it given us? Let's just do a real quick recap. It rewards volume, no limit on the number of services. We see what that does. Does not penalize poor quality. Does not. No financial incentive for multiple providers to coordinate their activities. Doesn't do that either. Focuses more on the short term than on the long term. So, how do we address that? And changes are happening. There's movements afoot, folks. So how do we get to value? Well, one of the things we have to realize about value is, and this is where some of the hard work has to happen, is understanding that value is quality and cost. But there's a fundamental impediment there. Many of us think that if it is inexpensive, then it is not of high quality. Well, that is not always true. And actually, we're going to have to build a healthcare system where those two are true, where actually there is high quality, but the cost has to be brought down considerably. One way to think about it is in hospitals, with hospital-based infections. There's an area where I think we all can grasp the idea is we need to decrease those iatrogenic infections as much as possible. And that actually results in decreased cost to the hospital, not to mention what it does for the individual that has to deal with the illness, and actually increases quality. So we have been able to do it in some areas. Now we want to spread that across the board. So the other thing that's really important is then understanding the cost equation. Because if we understand the cost equation, then we can actually get to the financing of those expenditures. So total expenditures are a good or service. It's the quantity of the good or services that is consumed times the price or cost of the good or service, right? So for healthcare expenditures, the big ones are utilization and unit cost or price. So total healthcare cost is driven by the number of episodes of care per condition. How many and what type of healthcare services are received in each episode is also extremely important. How many and what type of service processes, devices, medications, etc. are involved in each of those services is another area that we need to drill down on. And finally, the costs and prices of each of those individual processes, devices, and medications needs to be addressed by all of us together. This is a collective collaborative that's going to have to work on this to make it understandable so that we're all on the same page and we can actually achieve a financing system that actually then does achieve high quality and at a reduced cost. What's also important, though, because it is healthcare and it is very complicated, what are the costs that are non-preventable in reference to non-preventable conditions, and then which are the costs that are associated with preventable conditions? So we also have to be able to drill it down. So genetics is going to be important, and so obviously is going to be the environment. Understanding where the costs are concentrated helps then us to identify where cost reduction opportunities then exist. That is going to be a real game changer for us. We are not there yet, but that's where we need to go. So we had some Band-Aids in the meantime, right? Hey, let's do utilization controls. How many docs really love that one? Yeah, that's it, yeah. Require the providers to obtain pre-authorization. I know as I heck didn't like it. I'm going, why are they telling me how to practice medicine? You get a lot of pushback. It create detailed criteria defining the circumstances when services will be paid for and when they will not. Yeah, we like that too. Seems like you're micromanagement. You know what? It is micromanagement. Pay for performance. It's another one that popped up. Seems like that should do the trick. Bonus or incentive payments, or maybe we do the opposite. Let's penalize the providers. But most pay-for-performance systems focus on rewarding processes and unfortunately didn't concentrate on the outcomes. And so if you concentrate on processes, that's where you're going to get your changes, but not in the health outcomes. Capitation came along. That actually was kind of useful. paying a provider a fixed amount per patient to provide care for all of the patient's conditions, regardless of how well or sick they are. Controls volume, that's helpful. Avoids the micromanagement, that's also beneficial. Penalizes poor quality, sounds good. But creates a strong and undesirable incentive, though, for providers to avoid patients, though, who have multiple or expensive conditions. The cherry picking. So it was going really well until we got to that point. So didn't quite solve us, but it moved us in the right direction. So the better payment model, in my opinion, is really what's known as the episode of care payment model that's out there. I think we need to implement that and make sure, and let's find out what are the tweaks we need to do to that to make it work for each of our different communities based on the resources that exist. So the episode of care payment, paying a single price for all of the services needed by a patient for an entire episode of care, all care that occurs during maybe a fixed period of time, is one way to think about that. Now, what does that do if there's one payment for a fixed period of time for an entire episode? That involves everything that goes in there. As was being pointed out by Steve, all the different multi-providers, or by David Buck, as well as the organizations, hospitalization, ambulatory care, rehabilitation, that all needs to go into that. Imagine how difficult it's going to be to determine what are the costs to be able to identify a payment that's needed to cover the episode of care. Difficult? Yes. Necessary? Absolutely. So the amount of the comprehensive care payment would vary based, though, on the patient's characteristics. It must do that. One of the things we don't have is flexibility, folks. We've got to build flexibility into the system. We're smart folks. We can do it. The payment level for a particular type of episode should be higher if the patient has more complex needs. And as complex needs diminish, then let us adjust accordingly. Payment bonuses or penalties based on health outcomes, patient satisfaction, and patient utilization can be built in. Patients would receive incentives to use higher quality, lower cost providers. We can incentivize also the flip side of the equation. Let's be incentivizing, say, if you are actually going to a provider, which we have recognized based on the metrics of an episode pay model, that's who you should be going to, because we still don't want to take away the selection process that people should have. They ought to be able to do that. But they need to know that if you're not going to a provider who actually doesn't meet our criteria of really what we've identified as being high quality, low cost, then you're not going to be reimbursed or rewarded for that. However, if you go to one that does, maybe a portion of the savings that occurs to the system, what's called, the sharing that can happen from the costs that are avoided, can be sent back actually to the consumer. Something to think about. So anyway, the additional benefits of episode of care payment, physicians will no longer be restricted by fee codes and amounts. Imagine what can be done to administrative costs right there, just thinking about that. Incentivize prevention. It incentivizes prevention. It incentivizes improvement and maintenance of an individual's health, and facilitates coordinated care among not only the providers, but also the organizations the providers are part of. Now, there are some changes that are happening in Texas, because I need to drill down a little bit on Texas, I think. However, first I want to mention that on July 8th, 2015, the Centers for Medicare and Medicaid released its proposed rule for calendar year 2016 physician fee schedule. Why was that important? Get this, it includes allowing payment in the Medicare program for two essential components of the evidence-based collaborative care model of integrated care for care manager and for psychiatric consultation. Changes are happening. They may be slow, but they are occurring. HHS is charged with increasing the proportion of traditional Medicare payments tied to quality or value to 85% by 2016 and to 90% by the year 2018. That is literally around the corner. 75 metro markets, in fact, are already required to bundle Medicare payments for hip and knee surgery from the time of the admission until 90 days post-discharge. That's already happened. How about here in Houston, Texas? May 2015, United Healthcare and the MD Anderson Cancer Center are piloting a bundled payment model for patients with head and neck cancers. It's a 3-year pilot, just kicked off, just across the street. These are the things we need to be looking for and to finding out and learning from what's going on with these pilots. What can you do right now? Because I totally understand where Steve's coming from, and also David, because it's tough out there. But there are some things that aren't being taken advantage of, and they already exist. Telephone consultation codes, checked with HHSC, Health and Human Services Commission. They've been used less than 1,000 times in the past year. And these are codes that already exist that allow primary care providers to do consultation and get reimbursed for. Now, are the reimbursement rates great? No. That we need to work on. But we're not even using what we have. And it's under the Clinician-Directed Care Coordination Services. That's where it exists. The other one that already exists also is the 96,000 series. Medicaid's Health and Behavior Assessment Intervention Codes. The entire series is turned on for the state of Texas, folks. Health and behavior assessment procedures are used to identify the psychological, behavioral, emotional, cognitive, and social factors important to the prevention and treatment or management of physical health problems. Those aren't being utilized very much either. The HBIA services are provided by a licensed practitioner of the healing arts who is co-located in the same office or building complex as the client's primary care provider. So there's already some codes that we can take advantage of that can help us move and transform into the system that we've been talking about here. But I think one thing that this shows me is we've done a terrible job of communicating with each other, and we need to get better about that. When we have a transformation and change that's in the right direction that actually benefits us all, we have got to work together to be able to let all of us know what is available, what we can do, and then what obviously are the gaps and what are the next steps. Thank you.
Boy, I'm glad I didn't cut you off because you have teed it up perfectly. We're going to move into Q&A now with the audience, and I'm going to start the first question, and I'm going to go off of what you were just talking about. So we don't have any payers up here. We've got providers, and we've got advisors, and we've got a foundation, and we've got policy people, but we don't have any payers up here. So I want to ask all of you, from the provider perspective, how willing you are to take on risk, because that's what's involved if you go to something other than fee-for-service. And is there willingness in the provider community to take on risk? What does that take?
Well, Elena, I'll answer that.
Okay, good. We'll just talk to each other.
But I'll have to go back to when actually I was practicing, which obviously I'm not doing now. I'm heading up the Hog Foundation. But if it was proposed to me to be able to take on risk and you will eliminate some of the administrative costs and the headaches that come with them, I'd be more than happy to start looking at something like that. Because it is just such a large portion of time and energy, not to mention resources, that are being sucked up by all different types of practices, be it solo, which don't exist hardly anymore, including group practices. Hence the reason we try to bond together to be able to diversify those risks as well as expenses among us. But
so
that's just me.
Go ahead. Did you want to say something, Tim?
Just from a federally qualified health center perspective that sees less than 10% Medicaid or Medicare, there is no kind of requisite care coordination code that's not allowed through HRSA. So we're going to have some reform in order to be able to do that. So I think that's a beginning.
So, I think there already are, I'm not a provider, but, having worked with a lot of providers, what I'm seeing all over the country, including in Texas, is that providers are starting to take on risk. Sometimes on purpose, sometimes they're being made to take on risk. And one of the ways that that's happening is through the initiation of penalties for hospitals for potentially preventable readmissions and excessive emergency department utilization. So suddenly something that wasn't risk now is risk. And what a lot of folks are beginning to do is to say, well, now we have a real incentive to manage these high-need people, and we have to do it differently. The thing that's being recognized is that in order to manage that risk effectively, you have to provide services that are appropriately person-centered to the point of engaging people at the level of complexity and intensity that they need to shift the way that they're using care, because coming into the emergency room or going for a hospitalization has actually become easy in default. Many providers, feel overwhelmed by the idea of taking on huge population risk, but sometimes it's easier to start with a small N and to think about working with a payer who might be interested in working with you on that small N, so that it's less risky. So you're developing a smaller cost base for, let's say we're going to look at 50 high utilizers within our facility that are creating penalty, and let's practice either by ourselves or with a partner the development of an appropriate level of intensive home-based intervention for people with that level of complexity. And that's a good start because you learn, you're already under pressure, and you're not immediately putting yourself under a huge investment that creates even further exposure. On another level, one of the things that, Texas has a very unique system. I don't know that it's replicated around the country, and it's not universal across Texas, but the extent that you have, like Harris Health, a taxing hospital district, and the term is interesting. I mean, it's a taxing hospital district, but essentially it's when you look at it from the outside, and I don't know that other places have it in the same way, but it's a huge Harris Health and similar entities are a huge at-risk population health entity. Mm-hmm. And kind of, even more than the average health institution, they're finding themselves built in a model that's creating risk just by the way things are evolving. So, if your cost is based on building a bigger building and drawing down more procedures and getting higher tech, if we're shifting toward the idea that you're being at risk for complex people who have poor outcomes and multiple admissions, you have to shift the way you think. And they have to shift the way you operate and shift the way you cost account and fund. So in a certain sense, any large taxing district is already an opportunity for wonderful population health management experimentation. And Steve described one small example of partnering around the LMHA population. But the much bigger population in a hospital district are the ones that are not in Steve's shop, are the people who, like the woman I described earlier, who have not dramatically severe and persistent mental health conditions, but their mental health and social issues are enough to create dramatic, poor progress and higher cost inside their chronic health conditions. And so beginning to think about how do we use what opportunities we have to learn how to develop risk experiments and move forward is very important. So I'll stop there.
Elena, could I add one thing? I think the other thing, and to add on to Ken, is the concept of gain sharing. As we move into these new models and there's actually savings to be had, we need to make sure that actually we're spreading the joy around. Because, you think about a hospital and you think about an entire system, say the ambulatory care clinics that feed into it. If the ambulatory care clinics move into integrated health care and they actually are achieving the goals of decreased hospitalizations, what does that do to their bottom line? So if you want everyone to be part and parcel of this, we've got to make sure that where the savings are taken back and reinvested back into that that group, that relationship that exists, and allow the gain sharing to happen. Because if we don't do that, we're going to have folks wanting to drop out and not willing to take the risk.
Thanks. Let's open it to the audience, and we've got a mic that's roaming around, and feel free to ask a particular panelist or the panel as a whole your questions. Tell us who you are, please.
Hi, my name is Kara Hill, and I'm the executive director of a charity clinic in Katy. We're called Christ Clinic, and I'm going to say something that maybe feels a little backwards, because I know the city, Houston area, has moved from this charity clinic model a lot and changed charity clinics to become FQHCs. But I believe that we are the perfect model to implement what you're talking about here, because we don't bill, much to some of our funders or potential funders' chagrin. They would love us to, but we don't. We have volunteer doctors who are happy and willing and want to work at the top of their license with consults with psychiatrists so that we can manage people in our medical home. We have social workers on staff that are happy and want to do more of this behavioral health consultant model in our clinic. We are experts at utilizing medication assistance programs to help our patients get the medications that they need, and are moving into those medications that help with mental health. We work within a system and very closely with our local hospitals, so we make an extra effort not to work in a silo. We have quality outcomes that we track and report so we can prove the quality of our care, but we don't have those mandates that billing forces upon us. We have a very low medical cost per medical encounter because of our volunteer providers. So I think we're the perfect model for implementing something like what you're talking about here today. So if you want to talk to me about that, we are actually actively pursuing with our local hospitals, our local FQHCs in our area to pilot a integrated behavioral health consultant model.
Thank you.
Take care.
One of the areas we've just briefly touched on is medications when Steve talked about the pharmacy benefits of donated medications. One of the cost drivers, of course, for healthcare is medications. It's also a hindrance to integration in the sense that Harris Health, for example, depends on 340B monies to do their meds, whereas Steve depends on these donated drugs from pharmacies. You've also got a lot going on in the pharmacy field where the benefit managers suddenly, your insurance programs are starting to become benefit managers instead of having CVS, and then you have CVS stopping to pay for certain high-cost drugs. So how does all of that fit in as a policy issue around integration?
Steve?
Go for it, Steve.
Yeah, because of the substantial percentage of the adult population that at least the local mental health authority serves who are medically uninsured, our patients are a challenge for integrated care because physical health care can't keep absorbing more and more medically uninsured. And so the idea of trying to build a step-down program or having people served off-site has to be able to address their psychiatric medications. And there has to be a way of continuing that stream so that it's not laid at the feet of that physical health provider, because they can't absorb it, and they will have great reticence to partnering around that. So figuring out how you can retain access to, in our case, using PAP for the medically uninsured while they may be served in a different geographical location becomes a really important thing. Physical providers have enough challenge dealing with the physical medicine, let alone the psychiatric medication. So that's really got to be thought through and that continuing string provided.
So, go ahead, David.
I think you bring up a point which is another drop-off that we experienced from the FQHC perspective, where we could hold on to many complex patients, but for the costly medicines that our formulary doesn't cover, we have to refer them to Harris Health or to MHMRA or to a hospital, and therefore we get the discharge from the hospital, but there's 2 or 3 meds that we can't continue them on, and then we're in this kind of Sophie's choice, because you refer them and then they no longer have the other services of the clinic. So it's a challenge.
So let me just, a couple of quick comments. Like everything else, this is multi-determined, and there are things you can do at a program or a provider or an agency level to, as a physician leader, for example, to do things that intelligently manage pharmacy costs by attending to polypharmacy, attending to performance improvement, peer review around criteria for generic utilization versus more expensive brand name utilization. And so the idea, those things are implemented, but they're implemented inconsistently and in pockets. And, the idea that those things could be implemented more consistently would be very helpful. On a mega level, and I think probably many of you are aware that one of the big impediments is that there are legal and regulatory restrictions to mass discount negotiation and pricing with pharmaceutical companies on behalf of public payers, which is unique in the world. And, and there are some discussions about how to do that, and obviously there are significant counter pressures, shall we say. But it is helpful to begin to think about how to move into a position where the cost drivers and all the R&D costs are passed through to newly developed medications that are then paid down through the healthcare system, and to begin to move in a different direction that's more consistent with rational population health.
Thanks.
Hi, Allison Winnicky, University of Houston Law Center Health Law and Policy Institute. I wondered if you had any estimates or goals on the percentage of private practices that will move towards these integrated health systems in the next few years.
Ken, have you seen anything?
I haven't seen anything that's, I haven't seen anything quantifying that. I was in the Tennessee project. This is like a few weeks ago. They were bringing together an array of entities from across the state to be working with them in their person-centered medical home integration development on the primary health side. And what was impressive is that it was kind of equal at the table, large health systems that were hospital-based, FQHCs, and a lot of, Tennessee, like Texas, is a mixture of pretty urban areas and a lot of rural areas. And a lot of the places at the table were small private group practices who were rolling up their sleeves and trying to figure out how to take care of populations in rural counties, and had stepped in and were working on PCMH development. So I think where there's support for that, it seems like there's movement in that direction. If you look at the activities nationally of the primary care, I forget what the PCPA, Primary Care Physicians Association, or there's a lot of activity in primary care in general and family practice in general about all folks kind of moving into an integrated health population management model. Exactly how many actual primary care docs are moving that way, I don't know, but it seems like that is very much happening out in the private group practice domain where people work in organized practice settings.
Steve, and then Octavio.
I think one of the alarming trends that are going on, at least the most recent data I've seen, is the number of private practitioners who are opting out of Medicaid or restricting their Medicaid practice. And so, not interested in integration. What they are is saying we can't continue to absorb serving this population in this state at the rates they're being reimbursed.
Right. So as a policy issue, thinking, one simple way of saying it is if we think of it as a public issue, it's a little backwards, and it is a public issue, but if we think of it should be in the general interest of the state to make people who want to work in private group practice settings to take care of populations, that should be financially viable for any population that they're managing in their community. And all payers should line up around it, state payers, local payers, managed care organizations. Not that people should feel a financial incentive to not take care of the people who are most in need so that they bounce into the most expensive services paid for directly by tax dollars. It's a backwards policy, and I think that needs to be stated very clearly and addressed.
Your comment, your question also makes me think of another player that's not at the table here, which is major employers. So I know, for instance, IBM has a medical director, and he is working with across the entire nation, if not internationally, as IBM is looking at what kind of, menu they're going to provide to all their employees, and they're pushing that they want to see integrated care. Why? Because they're interested in the health outcomes, as was pointed out earlier about the disability and how it impacts actually workers' performance. That's another huge driver out there that we need to bring to the table to be part of this discussion as well, because I know that they are moving strong and very quickly in that direction.
So can I make a comment?
Make a comment.
So Octavio did a lovely job advocating for episodic care-based reimbursement. And I think episodic care-based reimbursement is a good thing, but it needs to be placed in context. And so episodic care-based reimbursement is a nice way of developing a cost basis for standard episodes that are diagnostically driven, like how much do we pay for an acute exacerbation of asthma, or how much do we pay for standard ADHD intervention, and so on. And a lot of states are working on this and able to kind of manage their core cost around those episodes more effectively in a way that's well partnered with providers and can be incentivized. However, in the thing that David was talking about, the idea of moving toward population health and population management, episode-based payment, even though it's better than procedure-based payment, is still only a part of the solution, because we have to learn how to manage people and populations based on their complexity, not just based on their diagnoses. So if you're familiar with Jeffrey Brenner and Camden and the work about hotspotting, one of the things they learned is that, this high group of people, I think David was talking about the 5% that draw down half the cost, that you could track cost much more effectively by looking at who was complex rather than by looking at their specific diagnosis. The cost trajectory for uncomplicated congestive heart failure, diabetes, COPD was pretty much the same. The cost for complex anything was higher. And complex anything means overlap between a chronic health one or more chronic health conditions, social conditions, behavioral health conditions, and the more you have, the higher it is. So as you move toward more complexity, the episode model falls apart, and you have to combine some good episode-based payment structures with incentives for providers and funders to work collaboratively to manage populations, and to be incentivized to work with the folks who are most complex in a person-centered and integrated team-based way to reduce increase people's engagement in ambulatory care, improve their overall health outcomes, provide them with flexibility so that you can do anything they need from transportation to in-home support, and reduce unnecessary hospitalization or excessive hospitalization and emergency room utilization.
Thanks. We're going to
take
one
Let me just say, hold on. Episode of care payment model, counterpoint. So Ken,
this is good.
This is how panels get fun, right?
So,
we're on the same team.
That's if you take the episode care model the way it's being implemented today. I didn't say let's implement the episode care model that currently exists. If you noticed, I said let's modify it and let's tweak it, because some of those very things I think can be put into it. And we probably would call it something different, not the episode of care model, because it definitely can be, for instance, payments. We've heard about bundled payments. You can put bundled payments as being actually part of the structure of an episode of care. However, the complexity, and that's where the flexibility and actually the risk adjustment that needs to happen for each of the types of episodes, because a physical episode like, oh, I'm having a myocardial infarction, a heart attack, is going to be a lot different than someone who's dealing with, say, an episode of first-time acute psychosis. However, I think that's where the hard work needs to be done, and we can move it forward.
All right. We're going to take one more question, then we're going to take a break. And I think the panelists are sticking around, so you should feel free to go ask anybody anything.
I'm Bob Kyler. I'm a psychologist, and I do part of my direct service via telemedicine and do consulting work in behavioral telemedicine. One of the challenges in integrated healthcare is if we aim towards co-locating and putting behavioral professionals under the same physical roof as physical medicine, we have a distribution and an access problem. It's going to be a bias towards high volume and urban. And I'm wondering about the role, kind of mindful of Dr. Buck, if there is a role for high touch, medium tech, and telemedicine and other technologies as a way of distributing scarce behavioral health expertise.
Okay. I don't know if if you were asking just David to answer, but the answer is yes.
Yeah, it is yes.
And the thing that I think you're hitting on is the ability to combine high touch. And by high touch, I mean high touch with both the people receiving service, but also high touch teamwork, without them necessarily having to be in the same physical location. And I think I think Steve said this: co-location does not equal integration. It may facilitate it, but I think there are plenty of examples of great integrated teams who may never or rarely sit in the same office. They're out in the field, they're scattered about, but they spend enough time together, however they spend it, to be a great team. And they have ways of interacting as a team with people who have complex needs, and technology is just totally underdeveloped. I was in a place in California, in a really weird county in California that's like really thinks it's in Nevada. It's not in California. But they had come across a techno vendor that had a platform for putting iPads in the hands of people who were at home with complexity. And the iPad, would allow for remote medical monitoring. It would allow for tele-teamwork in the home. And they were just starting, they got some innovation funds from the state to kind of begin to develop this model, and we were helping them to kind of plan their rollout in some of their measures. And it's exactly the kind of thing you're talking about. So, and by the way, since you said psychologist, I've been meaning to say this and I haven't, but one little microfinancing thing is that right now in our current reimbursement, people who do behavioral medicine, often psychologists but not exclusively, are often doing behavioral interventions that are supportive of people's health activation and health outcomes, but they're billed out of the behavioral health benefit. And there can be this incredible confusion back and forth. I mean, this happens at MD Anderson, it happens in clinics, where the behavioral health manager won't authorize it because the person may not have an established or bad enough diagnosis, and the health people won't pay for it because it's behavioral. And so just a simple thing to keep in mind is if we believe in that behavioral medicine is real, then it should be incorporated in as part of a health benefit. So we need to be thinking about stuff like that.
So one of the things I think Dr. Kyler brought up is this great benefit of telepsychiatry, and I think clearly it's been used in the Houston Fire Department. We've used it at Healthcare for the Homeless, where you can actually on a cell phone get a consultant right there on the line. But we've actually had this great new technology that's not really new, the telephone, where we called each other and we would talk to each other and say, hey, I'm seeing your patient. And that technology doesn't work that much anymore. And so part of that is that the billing structures don't allow those kind of consultations. They don't incentivize them. And so while I definitely think, and we use telepsychiatry as a service, it's available 24/7. That's better than having a psychiatrist just be twiddling their thumbs. So it's a great technology. I also think that we had something that worked before that we need to re-engineer the billing part of it so that we can not have an hour visit for a patient, but really a quick curbside consult that can get them on the right cardiac med, could get them on the right psychiatric med, and really save cost and time for everyone.
Octavio and then Steve. Yeah. And then we're going to call it a day.
Definitely agree with David there. And your question did make me think about a low-tech approach, which is going to the telephone. The Massachusetts Child and Access program that they have out there, they divided the state into 6 regions. Each of the regions then had actually a child psychiatrist, a nurse practitioner, and a care manager. And all they did was to have real-time telephone consultation ready for any child adolescent psychiatrist out there, any primary care doctor, be it a family practitioner or a pediatrician. And it took a while for folks to realize, you know what, they really will answer my questions in real time. But we shouldn't throw out low-tech approaches that are quite beneficial. The flexibility we have to build into the healthcare system tomorrow needs to make sure that we're not eliminating these really great approaches. Number 2, I really have a pet peeve with this whole thing about how we're soloing off now fill in the blank. Why in the heck are we doing that? We have an opportunity to, in fact, why don't we just make one code that just covers everybody? We could do it. We just have all these other interests that right now don't allow it to happen. But we need to keep pushing in that direction. And the third thing is that we haven't mentioned this, but also what's really important and is really integral to behavioral health integration is ensuring that the Mental Health Parity, Addictions, and Equity Act is actually fully implemented. It took 5 years to get the codes out, folks. That's ridiculous. Well, now we got to make sure that we actually don't lose it and actually we utilize it to its maximum.
Thank you. Yeah. Steve, close us up.
I think the point you're raising is very clear. One size won't fit all. And we have to think through how we develop models applicable to a given area. So telemedicine or other technology becomes very important in getting services to where the patient is and how that might occur with certain specialty services. But I think it is important to go beyond just the patient service and to be able to think through integration really speaks to communication among the provider team. And so that process has to be worked out on an individual basis in that setting. So that communication around patient care, the sharing of information, that hallway consultation that was referenced can occur, but it may occur via technology. So it's not just the patient service, it's really the communication with the teams. Everybody knows and is on the same page with regard to that person's care.
All right, we're going to wrap it up for the panel. Thank you very much for all of your time and attention and questions, and to you all for sharing your expertise. There's going to be a break. How long, Alejandra?
Thank you, Elena. We'll take about a 15-minute break until about 11:25, and then we will still wrap up by noon. We don't need a full hour for that, the second part, so don't worry about that. Thank you very much, Elena, and to all the panelists.